All right. Good morning, everybody. Thank you for joining us this Sunday for the transplant series of GlomCon. I'm Qasim Safa. I'll be moderating this session. It gives me great pleasure to introduce our speaker today, Dr. Erika Bracamonte.
Hello, everybody. This is going to be fun. I'm really happy to be here and happy to be sharing my Sunday morning with all of you and be talking about what some of these drug toxicities look like in the renal biopsies that we see, because it is something that we deal with very, very frequently. So I have nothing to disclose. I'm talking to you from Tucson, Arizona, so I thought it was apropos to put a beautiful picture of the desert. It looks quite like this, actually. I'm very lucky to live here. All right, so let's start with the case. This is a 54-year-old woman, and her ESRD was due to ANCA-associated GN. She underwent a deceased donor kidney transplant. She had immediate graft function. This is her immune suppression. And then about 5 weeks post-transplant, her creatinine is stuck. It's not going down. So we decided to go ahead and do an allograft biopsy. And from kind of a low to medium power view, you can see the tubules are not exactly back to back. It turns out her donor had some hypertension and a little bit more probably interstitial fibrosis than we would have liked. The glomeruli look pretty good, and I don't really see a lot of inflammation, but if we focus on some of these tubules here, and we're going to switch over to an H&E, you can see that these tubules are quite vacuolated. Their cytoplasm is very clear, and the nuclei are kind of dark, almost pycnotic looking, smaller than some of the surrounding nuclei. And then this is an image, it's another PAS of a vessel here. And you notice all these vacuoles in this smooth muscle. So our diagnosis at that time was tubular and vascular injury with features suggestive of acute calcineurin inhibitor toxicity. We didn't see any evidence of acute rejection or evidence of infection. And this was actually quite a recent case that we just had. So I'm going to spend a lot of time talking about calcineurin inhibitors because they are still a pretty significant cause of nephrotoxicity that we see. As we're all very familiar, these are very important drugs in terms of preventing rejection. They've really revolutionized what we can do with our transplants because they are so good at inhibiting the T cell activation and proliferation. But as we know, there are significant nephrotoxicity. So what are the risk factors? We know that if there's high doses, obviously, that can impact, and then older age of the donated kidney. And I don't remember exactly how old the donor was in this particular case. If there's other nephrotoxic drugs, especially NSAIDs, that can also predispose, salt depletion, diuretics. And then because these drugs are metabolized through cytochrome P450, any other drugs that patients are taking that will inhibit that are going to increase the exposure. And also patients that have genetic polymorphisms in the genes encoding the cytochrome P450. There are also certain drugs that will inhibit the efflux of the CNIs from the tubular epithelial cells, and that way increase the local exposure. So there's quite a list, very, very long list of the cytochrome P450 inhibitors, as well as inducers. And these are some of the drugs that can inhibit and induce the drug efflux pump. So we've known for a long time that these drugs cause nephrotoxicity. We know that the functional abnormalities are associated with vasoconstriction. This is an image from a very, it's a pretty old article, but I just love this image because it so beautifully shows us the vasoconstriction here of the afferent arteriole and the resulting ischemia here going on within the glomerulus. We know that this is due to reduced vasodilators, enhanced vasoconstrictors, leading to reduced renal blood flow and reduced GFR. Now, often